Hello, and welcome to today's panel, Addressing Racial Gaps in Food Allergy Research. My name is Dr. Kaye, and I serve on FAIR's Board of National Ambassadors and Diversity, Equity, Inclusion, and Access Committee. I'll be the moderator for this panel as we take a closer look into the racial and socioeconomic disparities that exist in food allergy research. Our panel of experts, Dr. Carla Davis, Dr. Ruchi Gupta, and Dr. Ahmar Iqbal, will share their perspectives and experiences and will discuss how we can work together to ensure all members of the food allergy community have access to the latest food allergy research and innovation. I would like to make some brief introductions before we get started. Dr. Carla Davis is a specialist in the allergy and immunology section of the Department of Pediatrics at Baylor College of Medicine. She is also the director of Texas Children's Hospital's Food Allergy Program. Dr. Ruchi Gupta is a professor of pediatrics and medicine at Northwestern Medicine, director of the Center of Food Allergy and Asthma Research within Northwestern's Institute of Public Health and Medicine, and clinical attending at Robert H. Lurie Children's Hospital, Chicago. Dr. Ahmar Iqbal is the Group Medical Director for Respiratory U.S. Medical Affairs at Genentech. One of his major projects is the Genentech Novartis collaboration with the NIH and the Consortium of Food Allergies. So let's get started. Hi, everyone.
Hello.
Hi.
Hi.
First, I want to thank you all for being here today to discuss such a timely topic in the wake of COVID-19 and racial disparities. And we're all experiencing this uprising in some form or another, personally or professionally. For me, it's been both. And while we're all just trying to get through this as a collective, I think many of us can agree that the pandemic has shown an enormous spotlight on racial disparities in the areas such as housing, education, the economy, the criminal justice system, and healthcare, which brings us here today. So we have lots to unpack in such a short period of time. So let's get this thing going. Can each of you share what brought you to the food allergy space? Dr. Davis, we'll start with you first.
Thank you very much. It's my pleasure to be here. I was drawn to study food allergies and try to make the diagnosis and management better for patients because I had two patients that impacted me. They were from under-resourced communities, and one was an infant with multiple food allergies, with eczema, whose mother had to quit nursing school in order to take care of him, and that impacted her family significantly. The other was a patient who was misdiagnosed with shellfish allergy, was from New Orleans, and really didn't know what else to eat, lost about 60 pounds, looked like a cancer patient or a TB patient, and turns out that he was probably diagnosed just because he had dust mite allergy. So, this impacted me because I realized families and patients are really impacted by correct diagnosis and management. So this is what has brought me to this field.
We appreciate you being here. Dr. Gupta.
Yeah, so similar to Carla, I started out in this field because of a patient. And what really got me involved, because I'm in pediatrics, and so I was a researcher working on asthma, and actually working on asthma disparities was my area of interest. And when I had this patient who had two young children with food allergy come and say, we really need more research, and I started looking at what had been done, and this is 16 years ago. So what had been done in the space of food allergy, what was really striking to me is compared to asthma, we knew so little. We didn't even have great prevalence numbers. We didn't know how many kids or adults were affected, and we definitely didn't know how it may vary by race, ethnicity, or income. And so as I was studying this in the asthma space, I thought maybe this is an area I can bring my skills to try to better understand food allergy and hopefully have an impact.
Great. Dr. Iqbal, what brought you here?
Well, first of all, I do want to thank FAIR for all of the great work that's been done by FAIR, and the research retreat in the recent past was just such a great way for everyone to get to know what's going on. I may be the senior in the room in terms of my hair and my age, but in terms of food allergy, I'm probably the youngest. I've been leading a medicine here at Genentech, and food allergy had been studied with that medicine, and Dr. Sharon Chandraja at Stanford actually talked to me about getting some resources for a trial that she wanted to do with the NIH and COFAR. And I basically told her, that we didn't have the resources. And then I thought about it, and I actually talked to one of my colleagues at work. And then I realized the devastation that this condition can have on a whole family, their lives, their food, their travel, their everyday sleepover and all of that. Then I realized that if there is a possibility to support this, then we should do it. So I discussed this within my organization, and we gave a letter of support and got behind this initiative. I talked to my colleagues at Novartis, who were also very much in favor of us working on this because it was such a huge unmet need. And then we talked to Dr. Robert Wood at COFAR and then the NIH, and it resulted in this study that's ongoing now for food allergy. And we Novartis and Genentech are supporting that study. It's led by the NIH and COFAR. But I just feel that in my career, if we do get to finish it and hopefully make an impact in food allergy, that'll be just, to me, the crown and the jewel, if I might call it.
Thank you for being here, and thank you for joining us in this food allergy space. So I entered the food allergy space because of my now 11-year-old daughter. She was diagnosed with 9 food allergies at 9 months of age and asthma around 5 years of age. She has not been a part of any clinical trials. However, she has been seen by several specialists, including Dr. Robert Wood at Johns Hopkins. But there is another piece of our puzzle, though. So both my husband and I have shellfish allergies. He also has asthma as a child. We both came from very humble beginnings, but neither one of us can recall ever visiting an allergy specialist. In fact, we both remember being told to just not eat it. No further recommendations, no referral to a specialist, no epinephrine auto-injectors, nothing. And so I share this with you all because my family and we now have the resources to take my daughter anywhere. But we recognize that many families don't, more specifically Black and brown families. And what we're seeing in the literature is that there's this huge lack of access, specifically with these communities, at a disproportionately higher rate than white families. What are your thoughts about why this might be?
I was just going to start with some data to back up what you just said, Kaye, because this is exactly, the kind of data we wanted to produce to show that. Because when I started in food allergy years ago, people really, I feel like, thought it was a condition that impacted, more white families and more, middle to upper income families. And, when you look at atopy and the relationship between food allergies, environmental allergies, eczema, and asthma, there is so much known about how asthma disproportionately affects, like you said, Black and brown families. And I was curious why we weren't seeing this in food allergy. So as we did these large national prevalence studies, we found that it is the same, that it does disproportionately impact Black and specifically Black community more. And specific foods like shellfish are significantly higher. But this is all kind of new data that we're starting to understand. And then back to your access issue, when we talk to families, they said the exact same thing. When we look at the Medicaid population, we are noticing that only less than 1% are diagnosed with a food allergy compared to 8% of the population. And a lot of this is because they're not able to get to an allergist, to a specialist. And when we looked at the economic data, we found that specifically Black and brown families are spending less on specialty visits and more on emergency department visits. So how come, what are we doing where they're not getting that care? And I'm sitting in my clinic, which predominantly sees Medicaid patients. And I see it in my own clinic because I see so much asthma. And a lot of times they don't even tell you about their food allergy because asthma is so important, and we have to get, a lot of those questions answered in the medications, and they just avoid the food that caused symptoms. So there are a lot of barriers that really need to be addressed in this area.
Thank you for that.
Yeah.
Dr. Davis?
Yeah, I think because of the work Ruchi has done, we now know where the barriers are. And I think of a recent publication where there are clear gaps in knowledge and then how to manage food allergies. And I see that every day in my practice. I think there are a few reasons I've thought about this access to care issue. And one very large issue that came up just this year for me was that Medicaid patients don't have as many allergy specialists to see. Because there was actually someone who wanted to refer a patient to the greater Houston area, and it was actually an allergist who just wanted to refer to a different location. And he said, my patient has Medicaid, and you're the only person who's listed. And so it reminded me that allergists in the community really have to make sure that they can keep their businesses open. And that goes back to the fact that Medicaid patients, when they're seen by an allergist, that allergist is paid much less, right, than a privately insured patient for that care. And so in order, I believe, to truly make a huge difference in access to care, those economic reimbursements for the doctor's care for Medicaid patients really would need to change. The other thing that I think would make a huge difference is just the relationships between specialists and primary care providers, really outreach and education to pediatricians and even internal medicine docs, because we know we have adults now. Ruchi has shown that adults have food allergies, and we need more adult physicians to take care of them. So really increasing that access and education to primary care providers so that the referral can happen, and then ensuring that not only does the doctor not have to struggle in their practice to see that patient, but then also it's not a huge financial burden on the patient, because that also a role. So there are many factors that can impact access to care.
Yeah, and I think both of you make interesting points, because as we continue to navigate this space, we know that the prevalence of food allergies has significantly increased since the 90s. I think the last number I saw was like 377% in a diagnosis of anaphylactic food reactions between 2007 and 2016. We're also learning that, as you both have mentioned, that these disparities around race, which again had initially been thought to impact more affluent white families than the Black and brown communities. And then, so that tells us that food allergies doesn't care what you look like or what you have, and that no one is immune. And as you mentioned, Dr. Davis, that one's socioeconomic status plays a significant role in gaining access to specialized medical care. Some other things, as you said, many factors, the ability to purchase costly allergen-friendly foods, or whether or not treatment is just simply worth it, weighing the pros and cons of being able to keep a roof over one's head versus just simply avoiding an allergen, as it was for both my husband and I when we were growing up. And so I guess, in my thinking is, I believe the easiest part of this equation is that lower socioeconomic status may mean less access to medical care, but as Dr. Gupta's 2018 study pointed out, Black children and those on Medicaid were diagnosed less frequently, and they weren't getting access to care. However, there was more emergency room visits because they weren't getting specialized care. So collectively then, what are your thoughts about how we can address this? I would love to hear from each of you.
Well, if I may take a stab, you guys work with food allergy every day. I do, but not to the extent that you guys do. Patient organizations, those are really whom we should be looking to. Because to me, it starts with the motivation. It starts with, okay, so is this a rich man's disease? And what will I get out of it? You will still tell me to avoid, but I think food. So to me, when I see this fair community and how powerful they are because of their knowledge, because of their supporting each other, because of what they're doing for all patients or people that are affected with food allergy. I think when we look at the specifics of what we need to do, we do pretty well in terms of the care when patients come to your clinic. But I think to me, it's engaging with the community and not just people who have food allergy, but the people around them. All of us need to be empathetic to what happens in the lives of these people. And as you mentioned, it's not a rich man's disease or a rich woman's disease, or Ruchi, I'm sure you can explain that. Everyone knows now the way the food that you eat, the cultural habits, they do have a bearing on what you develop later in life. So there are so many aspects that it's down out of the clinic into patients' homes and lives. So I think we need to partner really, really in a strong way with patient communities.
Yes, and I thank you, Dr. Iqbal. I think also having really getting into the community, like he said, has been really powerful. So we were able to partner with the Houston Independent School District to see if we could increase the availability of epinephrine for children in the school, because they spend so much time in schools. And by partnering with that community organization, and then educating that community of nurses in the schools, we were able to make a difference in not only the number of children with food allergies that had epinephrine there at their school for them, but then also education for families. I do think, as the studies have shown, there's less educational efforts for families of lower socioeconomic status in emergency rooms and offices. There are disparities in administration of food action plans and epinephrine, and that could be caused by a few factors. I do believe having the knowledge, so if physicians have the knowledge that there are these disparities that exist, then we can actually proactively try to give more educational resources. We can also guard against spending more time with one family versus another family. Having social workers or nurses in our offices specifically talk to those patients more in depth. So I do think that could make a difference in this area, more education and understanding the disparities. Yeah, one more point I do think I could make is that outcomes typically can be improved when there is patient and provider, whether that's a nurse or research coordinator, concordance. So sometimes having that cultural connection can also make a difference in specific communities.
And I agree wholeheartedly with everything that's been said. So I guess I will add on that I think the 3 areas that we really should focus on that was mentioned is the families, the children, the adults themselves who have the food allergy, by giving them, as Carla said and Ahmar said, more education, more awareness, because what we learned is that they are not clear about the management of food allergy. They told us that, they haven't. Food allergy is so complicated because it can impact any organ system. So it's very confusing, and understanding, the severity, the potential severity, what to do in case a reaction occurs. And the forms we have are also very confusing. And we're learning this all over medicine. We need to make them simple and understandable, because as patients even come to see us, they remember, less than half of what we say, right? So we know this. So how can we give them the tools they need to understand, what food allergy is and how to properly manage it? So that getting to the patient, and I agree that organizations like FAIR are instrumental in that because they do have a reach. And I am really proud to say that I think all three of us are working on an initiative for increased inclusion in FAIR's patient registry and really making an active attempt at reaching out to families who are typically not part of the registry and trying to see what we can do to support all Black and Brown families, especially in their management. So I think that is one. The other one is also what Carla mentioned is how do we get them access to allergists? I mean, I work in a predominantly Medicaid clinic and the wait for any specialist is much longer, and so how do we change that on a policy level? How can we initiate some kind of policy to try to have more access? And I think this has been a constant problem forever, but I do think it's time and, it's the right time to really focus on how to make change happen there. And then the third group are the pediatricians, because pediatricians do see everyone. And so how do we help them have some resources while they're waiting to get to an allergist that they can help manage families, adults and children, and internists too, like all primary care physicians, to be able to give them the education and resources they need. And that goes back to a little bit of what Carla was saying about that medical home where the allergists and the pediatrician, the internists, and the nurses are all in alignment with care. And it's work, but partnering with organizations like the Quad AI and the AAP and really pushing out this initiative. That's what happened with asthma. Right now, pediatricians are pretty adept at understanding and managing asthma and getting them to a specialist. And we need to make the same thing happen with food allergy.
So one of the things that I wanted to add, and I just feel like I would be remiss if we overlook the historical context of medical practices as it relates to Black and Brown people in this country. And we know from our history books that there have just been generations of cultural mistrust or distrust in healthcare systems, particularly as it relates to Black and Brown folks in this country. And these histories have been well documented, dating back to slavery, and now burst in the forefront with the coronavirus. And so, I could think about particular instances where researchers have gone into communities and haven't been forthcoming about why they're there and what those have done to those communities. And, I'm thinking specifically about the Tuskegee syphilis study, or even looking at or hearing about the stories of, the father of gynecologists, his experimentation with enslaved women without the use of anesthesia. And so these stories go on and on and on, and you hear about them. And then now, even in today's age, we're seeing high maternal mortality rates in Black women. And now this gaping hole as it pertains to the pandemic and how it's continuously disproportionately affecting Black and Brown populations. And unfortunately, these atrocities, so to speak, have continued to exacerbate an already distrustful segment of our population. And so I know that I had shared with you all earlier that, my daughter hasn't participated in any kind of clinical trials, and it hasn't been necessarily due to, my own fearfulness of having to deal with fear that we have about these stories that are, in the back of our minds, but it was has to do with primarily due to her comfort level. So having said all that, as we say in the mental health space, representation matters. And so I want to shift gears a bit and just talk to you about what the current status of diversity is as it pertains to ethnicity in the food allergy space. What are we seeing there? What are we seeing at your clinics and within your practices?
Yes, so in my clinic, I do see a wide variety of ethnic groups, but most of them in my specific clinic are of a higher socioeconomic station in life. And the patients, however, that we treat in our research studies are definitely kind of have more financial resources and more flexibility in their ability to participate in these trials. So there are some disparities there. And I do think in order for there to be more representation in research studies, the knowledge that there is this potential lack of trust for research in Black and Brown communities must be addressed by us as researchers. Education is really an important part of that, emphasizing that sharing what the advantages are for that individual patient for participation in the study, if there are some, and many food allergy studies do have advantages, even if there is a placebo. I think all of these things are helpful to inform the patient so that we can relay the fear of participation in research. The other thing I would mention is consenting a patient is so important now compared to when these other atrocities were performed. Now, any researcher that has a patient enter into a research study has to explain every single thing that is going to happen in the study. This takes hours, but it is really an essential part of the research process. So I believe that because of the laws that have been put in place, Black and Brown communities shouldn't be as fearful of research, because every single thing will be written down in a consent form and explained, and a patient always has the right to refuse and ask any question they want. So I want to encourage people who are in Black and Brown communities to consider research, because it will help not only them, but the entire community.
Can I add something from a research perspective? I think, first of all, we do need to do studies and trials in areas served to minority patients. So I think that helps. But I think I come back to, again, organizations like FAIR, because my view is that we need diversity in our trials to answer the scientific questions. If we limit enrollment in our trials to particular communities and ignore others, and particularly in food allergy, as I mentioned, I mean, there are factors that predispose to, even when you are within your mother's womb, that may affect, what happens later in life. So I think the earlier and the cultural nuances in terms of what kind of food we take, so those are very important in my opinion. And my only hope is that, again, organizations like FAIR, if we can somehow make them go to the appropriate sites like clinicaltrials.gov and post it on their websites and inform their members that this is a trial going on, and do their best to educate patients before they even come to the research center to say, we need you. It's not just that you need to be in the trial, but you need to make that contribution to research so that everyone benefits, everyone irrespective of their color and background and all of that. So that is my plea, that while we do things at our academic level and health policy and all of those, but I think organizations like FAIR, and that may apply to other conditions outside of food allergy as well, that they have the trust, as Dr. Davis mentioned, but also the information to say, that I need to participate in this trial, to not only for myself, but also for the people around me.
So, one big factor that you brought up is the trust factor, which is so significant. And we're doing a study currently that's funded through the NIH. One of the, I think, first studies to look at racial and ethnic differences in food allergy. And so the goal of this study was to enroll equal numbers of Black, Latinx, and white families and follow these children prospectively and longitudinally to really understand differences in the way they were diagnosed and developed food allergies all the way to microbiome and biomarkers and daily living and quality of life. So we're really excited to get some answers, but even in our study, we've struggled to really enroll Black and Brown families. And a lot of it is that trust, and a lot of it is the barriers that we've discussed. And, one of the things we found is absolutely, it has to be something that they believe not only is going to support, future generations to come, but also, what are we doing for them by having them in the study other than just following them? So what can we do? What are the needs that they have that we can help support? And I think this has become a really important issue. And even through working with the Quad AI, we're just launched a survey to look at how many allergists are currently asking questions around food insecurity. So if you tell someone they have a food allergy, but you don't know, if they can even afford the food, then what are they supposed to go out and do? But you can't ask the question if you don't have resources to give them, right? So it's like this whole structure that we need to really improve upon. And what's so wonderful to see are there are organizations that we're partnering with and FAIR is partnering with, like Food Equality Initiative, where they're really trying to figure out how we get food allergic people safe foods, right? How do we make this happen? And then how do we change it on the policy level with WIC, with food pantries? There are so many layers that we just kind of, by actually having these conversations with our patients to really understanding their barriers, then we can start developing interventions and putting in solutions. And that could be working with organizations like FAIR. It could be going to the NIH and studying it to get data to change policy. But it really, I think the conversation has started, which is what I'm really excited about. And, working with this amazing panel here of all three of you, we all care about it. And that's the first step. We got to care, and then we got to move forward and do something about it. So it's a Maya Angelou quote. It's fine when all you know is what you know, but when you know better, you got to do better.
So then, quick, I know we got a few minutes left. Just a quick one-liner. What evolutions do you all hope to see in your career in this food allergy space?
Yeah, I hope to see all food allergy families, whether they are rural, urban, minority, non-minority, all families with great diagnostic access. They know exactly how to manage their disease, and they're represented at the same rate they are in the population. So I really am looking for equality in all areas of food allergy across the board.
So I second what Carla said, and I'll build on it to say, definitely want to see equal access to things that are evolving now, like treatments and prevention, and make sure we know how it works in Black and Brown populations as well as white populations. And if there's any differences, any predictors that we should know about. So moving towards including them in these studies will then move towards our understanding of how they work in all populations. So yeah, so I'm very excited because I think in the 16 years I've been doing this, I've seen so much evolve, and this piece is the most important to me. So watching this be talked about and people come into the mix to really make it happen is excellent.
Yeah, I don't practice now, but I think at least from where I am, we are placing a lot of emphasis on diversity and inclusivity in our trials. It's not easy. So I think we've talked about some of those barriers. So that is our goal. But I would like to be a little aspirational and say that maybe our vision should be that we find a cure. That prevention is great. That's what we've been done. But hopefully we all put our heads together and find a cure.
Great. So I want to thank each and every one of you for sharing your time and knowledge today. It is my hope that we can not only gain a better understanding of the communities we serve, but also of ourselves and how we perceive others based upon those lenses. It is also my hope that we can find ways to deconstruct systems that have historically marginalized or disenfranchised people of color in this country. So having said all that, we're going to now open it up for Q&A, and we'll answer as many questions as possible.